Thank you again for having me here. It's a real pleasure and privilege to be here, and great to see such a good turnout. As I said, I think it's so important to raise awareness for this condition because not only do we need to educate physicians in the front line, emergency room physicians, so they don't turn patients away, but also, the cardiologist taking care of you, and also patients themselves and your family, so they know when to bring you to the emergency department when you have pain. So my task today is to talk about medical treatment and interventional treatment. Now, the way we treat patients with SCAD really depends on how patients present. Fortunately, as you can see, there's a whole spectrum of how patients can present. They can present with a big heart attack, with being hemodynamically stable, meaning that they have low blood pressure or they have serious ventricular arrhythmias or serious abnormalities in their rhythm that is life-threatening. But fortunately, the majority of patients, when they present with SCAD, have a small heart attack, and the pain has settled by the time they reach the emergency department. So the treatment for these patients are a lot more different from patients who have a large heart attack. So when we talk about treating patients with SCAD, a few different perspectives. First of all, we need to manage them in hospital acutely. And then there are long-term management strategies as well, especially as it pertains to trying to prevent having another recurrent tear. So focusing on acute hospital treatment to start. Now, this document, if you haven't read this is really an incredible piece of work from several key SCAD experts, including Esther Kim, who's speaking after me today, and Melissa Wood, and myself, Sharon Hayes, and a number of other collaborators here. And this really distills, the contemporary knowledge we have about this condition. So I urge you to take a look at this document if you haven't already. But as this document outlined, the management of acute SCAD for patients presenting to hospital typically is a conservative management. So in patients who do not have high-risk features either on the coronary angiograms or clinically, meaning they don't have ongoing chest pains or low blood pressure, etc., the majority of these patients we can treat conservatively without needing stenting or bypass surgery. But treating medically doesn't mean that we send a patient home right away. This means we need to observe patients in the hospital for at least 3 to 5 days because they can have recurrent chest pains and life-threatening arrhythmias while in the hospital. Now, for patients where they have ongoing chest pain or ECG changes or they are unstable, then we have to think about doing revascularization, which can be either stenting or open heart surgery. And stenting is typically preferred because it is less invasive. So if anatomically we can put stents in, this will be ideal versus doing bypass surgery. So typically we would reserve bypass for patients where we don't have an option for stenting or they have involvement with SCAD of the left main trunk. And you've heard this earlier, a description of the coronary anatomy. So the left main artery is the main branch that comes off from the aorta to supply the bulk of the left ventricle, which is the pumping function of the heart. So if you have a dissection of the left main, it means a big territory is at risk. And a lot of patients with left main dissection result in requiring bypass surgery. But for other dissections in, say, the front artery, the LAD, or the circumflex, or the right coronary, most of these cases we can treat with stent if we need to. So starting off with conservative medical therapy. In the Canadian SCAD study that Melissa alluded to earlier, we've presented 750 SCAD patients that we enrolled over the past 4 years. The majority of patients with SCAD in our series, 86%, were actually treated conservatively up front. So the majority of you will be treated without the need for intervention. For these patients, while in the hospital, the incidence of needing subsequent revascularization was only 2.3%. So the vast majority of patients that we choose to treat medically actually do well on medical management. And so overall, 84% were just treated medically in hospital. So when we think about treatment for patients who present with a heart attack to the hospital, these are the standard goals. Number one, we want to prevent these blocked arteries from re-blocking again while in hospital. We want to prevent mechanical complications such as rupture of the ventricle, the heart muscle, for instance, trying to prevent a recurrent heart attack, say, during the next few days or next weeks to years, and also preventing sudden cardiac death. And the typical armamentarium of medications that we use for standard heart patients are the following here. And many of you will be familiar with these antiplatelet agents, which are aspirin, clopidogrel, beta blockers, which most of you you, I'm sure, hate. ACE inhibitors, statins. So these are very standard medications that when we treat cholesterol heart attack patients, we know that these agents are very beneficial. You can see these check boxes here where a lot of these agents improve survival, they decrease the chance of having another heart attack, reduce your chance of angina. But what is the evidence here for SCAD patients? Now, we still want to do the same thing. We want to prevent reblockage of these arteries. We want to prevent these diastolic complications and sudden death. But where is the evidence? And that's what these data are lacking. We don't have a lot of data because the number of patients we have in these studies are limited, and we don't even have a randomized trial to compare one agent versus the other, and we don't even have a trial that compares stenting versus no stenting. But having said that, most patients with SCAD typically will be on long-term aspirin and a beta blocker and some duration of therapy with another agent that's antiplatelet, such as clopidogrel. So typically, acute management is aspirin and beta blocker, and I'll go through each of these ones in a little bit more detail. And most patients will be on a short duration of clopidogrel, and you may be on an ACE inhibitor, you might be started on a statin, and you might need calcium channel blocker or a nitrate. So if you look at the now 327 patient cohort, acutely at discharge, 92% with discharge of aspirin, 60% with an additional antiplatelet therapy, which is clopidogrel, 80% on beta blocker, and limited numbers on calcium channel blocker, about 50% on statin, 60% on ACE inhibitor. So what are each of these agents? And I think it's important to go through them because then it can instill in your mind why we want you guys to be on these medications. So So aspirin is a standard agent where we want to inhibit platelets from forming. So when you think about SCAD, yes, SCAD is due to typically tear in the artery wall, so you have blood in the wall of the artery. You can also have disruption of the intima. And when you have a little split in the artery wall that connects to the true lumen, platelets can adhere. And the platelets can now become a bigger issue, become a clot. And now you can have even worse of an issue, not just a blocking of blood flow from the intramural hematoma, which is the blood in the wall. Now you have blood clot in the true lumen that exacerbates things. So aspirin is really the first line to prevent additional problem related to SCAD from the intimal tear. So aspirin prevents platelets from sticking together. And in the acute presentation, sometimes aspirin is not enough. And we know that in standard cholesterol heart attack, you need additional agent, what we call additional ADP receptor antagonists. So there are a few of them nowadays, but the most commonly used ones would still be clopidogrel. Sometimes we use ticagrelor, or even a little bit more potent. So you think of these ones as super aspirin. So most of you, if you're started on clopidogrel, you will be on it for limited periods of time, typically about 1 to 3 months after a heart attack, but not long term. Unless you can't be on aspirin for allergy or other reasons, then you might be on clopidogrel long term instead of aspirin. Now, beta blocker is absolutely key. Every single heart attack patient, irrespective of the cause of heart attack, should be on a beta blocker because we know that beta blocker reduces your chance of dying from arrhythmic death from bottom chambers of the heart. So you can get these fast ventricular fibrillation and tachycardia. Beta blockers prevent that. Beta blockers also help with remodeling of the heart, essentially decreasing fibrosis. But very important for SCAD patient, there's an additional benefit. And this additional benefit is it reduces the arterial shear stress. So if you think about when the heart pumps, it squeezes a whole bunch of blood into the aorta and into the heart arteries. And each time it pumps, there is a lot of force going through the arteries. And we measure this force by this, dP/dt, which is the pressure change over time. And if your heart is pumping really strong, it increases the shear stress more so than in a heart that is weaker. So beta blocker actually reduces the shear stress. And so it does two things for SCAD. So beta blocker reduces your chance of dying from arrhythmic death, and also this decreases that shear stress. And this is the only study that we know that showed if you're on a beta blocker, your chance of having a recurrent SCAD appears to be lower than patients not on a beta blocker. So this is from our series that we published last year. So the hazard ratio is 0.36. So you have a 2/3 lower chance potentially of having a recurrent heart attack. So I always tell my patients, it doesn't matter how bad you feel about being on beta blocker. You're going to feel really fatigued, especially for the first few months. But this is the only agent that we really have some evidence, even though not the strongest evidence because he's not in a randomized trial, but this is the only agent that we have some evidence that that being on a beta blocker can reduce your chance of having another recurrent tear. So it's very important to be on that. And you can see another important clinical predictor here is high blood pressure that increases your risk potentially having another tear by over twofold, okay? So what about ACE inhibitor? ACE inhibitor reduces blood pressure. It improves overall pumping function of the heart. So a lot of you would be on this as well, especially if your heart muscle are taking a hit from the SCAD itself. Statins, on the other hand, really is addressing patients with abnormal high LDL cholesterol, the cholesterol forms of heart attacks. So most of our patients with SCAD typically do not require statin. And in fact, one of the earliest series from your Mayo Clinic showed that patients who are on statins might have a higher risk of recurrent tear, although subsequent series haven't quite panned that out. In our series, we didn't show statins to be harmful, but nevertheless, if there's no need to be on medication, and most of our patients are young, they don't want to take additional drugs if they don't have to, so this is one of the agents that we would stop. Now, calcium channel blocker really helps patients where they have spasm of the arteries, and so patients who, if they have additional symptoms of recurrent pain due to spasm and nitrates not controlling that, then calcium channel blocker will be of an additional help. But most of our patients are not on this agent. And nitroglycerin is one agent I would tell my patients, always make sure that you have, a nitroglycerin spray with you in your pocket. So when you have pain, one way to help tell whether it's from epicardia, which is the big vessel causing blockage of blood flow, would be to take a spray of nitro, and you want to take that, usually not when you're standing up because you can pass out, so we want to take a nitro, make sure you're sitting down or lying down, take a spray, and then wait 3 to 5 minutes and see the pain goes away. And what I usually tell them is if you have pain that is more intense than your usual pain, because a lot of patients with SCAD, over half would have recurrent pain after their SCAD event. I always tell them, well, listen to your body. And if you have pain that is more serious than your usual pain, and you take sprays of nitro and you wait 5 minutes for each spray, and after 3 sprays, so now it's about 15 to 20 minutes later, your pain is intense, more intense than your usual pain, and it's not clearing with the nitro spray, you show yourself to the emergency room. It's better to be safe than sorry. That's where we can check your troponin values. All right, so in our Canadian SCAD study for the 750 patients, I just want to stress again that aspirin was used in 94% of patients at discharge. The additional ADP antagonist clopidogrel in 67%, beta blockers in 85%. All right, so you should be discharged home on a beta blocker, and if we look at long-term follow-up beyond that, 80% remains on beta blocker. We really try very hard to make sure our patients stay on beta blocker, but sometimes people just feel extreme fatigue and just could not function with beta blockers. And in those cases, we would say, okay, fine, let's try you off that. And if it makes a difference, you stop it, you feel a lot better. Then we can eliminate it from your medical regimen. But typically, we prefer that you're on it. Other agents like ACE inhibitor, again, about 50 to 60%, statin about 40 to 50%, and the other agents like nitro and calcium channel blocker, taking it daily is quite minimum, less than 10%. Now, in terms of medical therapy, we know that the majority of patients, if we were to treat them conservatively, in these 84% of cases, the majority these arteries would heal. And in one of our series that is under revision right now for publication, 130 patients where we had repeat angiograms. We don't routinely do repeat angiograms anymore, but in some of our earlier experience where patients have large vessel SCAD or recurrent pain, we don't know what the cause of the pain is, we would repeat the angiograms. And what we did see is that, if we repeat angiograms more than 6 weeks after, we typically see healing in the vast majority of cases. And that's the natural pattern for this condition, which is why we can get away with just medical treatment without doing revascularization, all right? So in a hospital, what if our hands are tied? What if you have ongoing severe chest pain that is real? Real meaning is due to inhibition of blood flow to your heart muscle, and you're actually having muscle cells that are dying. So in these cases, we got to think about stenting or open heart surgery. So in our series in the CanSCAD study, 14% of patients ended up requiring stenting, well, PCI. And what are the outcomes? Actually, before I go there, why did we do PCI for these patients? So if you look at the reasons on the panel on the right, a lot of them have ongoing chest pain, 39%. ongoing ischemia, the ECG doesn't lie. So if the ECG shows worrisome features of lack of blood supply, that's about 35% of cases, you would have to intervene. And sometimes it's dissection involving very important vessel, large vessel, big vessels, left main trunk, etc. Those are the cases where these PCI were being carried out. In terms of outcomes for PCI, we know that PCI is often very hard in patients with SCAD, so unsuccessful in 30% of cases, and partially successful is successful in about 70% of cases. And in these patients, 65% required stents. 5% had this novel technique called cutting balloon, a small proportion just balloon angioplasty alone, and a small number of cases, 14%, where they couldn't even get the wire down, so they couldn't even try a balloon or stenting in these cases. Now, how did our series compare to what's out in the literature? If you look at earlier series, where the number of patients who underwent stenting or PCI were quite limited in each of these series, the overall success is very much about the same, somewhere between 50 to 80%. But if you compare that to a standard heart attack patients with cholesterol blockage that I put a stent in, I would say this is dismal, because my success rate for a general stenting for a cholesterol heart attack is 99.9%, all right? So this is 60 to 70% is a very pathetic rate of success for stenting, because we have model technology, very modern stents. And then the challenge is because SCAD is a whole different kettle of fish. Why? Because number one, you can have a false lumen. Sometimes interventionalists may not be able to get into the true lumen. If you can't get into the true lumen, you can't put a balloon or stent down. And even if you get into the true lumen, because you have blood in the artery wall, whatever you do, I always, give the analogy to a pimple, right? You have a pimple, you squeeze the pimple, well, it's got to go somewhere. It's like you have blood in the wall and you try to squeeze with a balloon or a stent, well, that's got to go somewhere. So a lot of times you now track that blood in the wall downstream or upstream, and worse, it goes up to the main trunk, and now you need open heart surgery. So those are some of these challenges. And sometimes the SCAD is so extensive that you need many, many, many stents. And when you need that, well, then you run into issues with re-blockage down the road. Or sometimes, it's so extensive, it goes to the tip of the artery. Well, we can't put stents down at the tip of the artery. So it really limits our ability to do a good job with stenting. And one of the other major challenges, too, is that most interventionalists in the world have not really dealt with stenting a SCAD artery, okay? They might have done one or two in their lifetime. We were fortunate. I've reviewed over 200 cases of stenting for SCAD patients because of the series that we look at. And so we're able to come up with an algorithm to help guide, well, if you were to see a SCAD lesion, how should you treat? So we came up with an algorithm that hopefully will be helpful. And I'll just show you some quick examples. So this is an example where a patient had a SCAD in the mid-LAD here. I'm not sure if you can see it very well, but you can see that disruption here, right? Multiple lumen, dye, hang up in the mid-LAD. The easiest way to treat for a SCAD lesion is if your SCAD is not very long, and if we can put a stent that is longer than the dissected area by covering both edges by at least 5 millimeters, that is the easiest way to treat it. And most of the time you can do this without trouble. So this is after a stent. You can see the artery flow is normal. The artery is now is big and juicy. So this is very easy. And here's another example where this person had a type 3 SCAD in the mid-LAD again, and you see the vessel is essentially occluded. But fortunately, type 3, this is a relatively short to focal lesion that, again, we can cover with a long stent. So the stent covers both edges by at least 5 millimeters, and this is just a simple get across, squeeze your stent open, and here you are. So if you're lucky if your SCAD is short, but we know that most SCAD is not short, and that's what the challenge is. So if you have a long SCAD that starts from here in the mid-LAD, okay, that supplies the front of the heart, it goes all the way down to the bottom. You can see that's extensive. So there's no stent long enough to cover this in one go. And then so the challenge is, well, where do I stent? Do I stent in the proximal part first and then the distal? I know that if I stent either or stent in the middle, I can squeeze the blood and make it worse. So one of the strategy that we've suggested was try and tackle the edges first. So here we put a stent at the bottom, at the distal edge, and then we stent the proximal edge before we tackle the middle. Okay, and so this takes up the edges and prevent this extension of the blood to both sides of the artery. And here you can see that the artery is nice and juicy after that. And a new technique for doing intervention now for a patient with SCAD is actually try not to put a stent at all. So if you have a really long lesion of SCAD, it may be more feasible to not put a stent in, because then you don't run into issue with reblockage. So an alternative is to let the blood in the wall bleed back in the true lumen. So to do this, we have balloons that have razor blades on them, what we call cutting balloons. Okay, literally they're razor blades. They're like 3 razor blades in the balloon itself. And here this is the balloon going up, and with those razor blades, it actually puts a slit in the intimal wall and let the blood in the wall of the false lumen bleed into the true lumen, and now actually opens up the main channel. So in this particular example here, you can get away without putting stents. And this patient had ongoing big ST elevation, ongoing chest pain. And after we put this cutting balloon, her pain resolved, her STs went down, and we actually didn't need to put stents in. And she did really well in follow-up as well. So this is an alternative to putting stents in. So what if we run out of tricks and we can't fix you in the cath lab? Now, unfortunately, the next alternative is bypass surgery. What is the evidence for open heart bypass surgery for SCAD? Unfortunately, there's really not a lot of evidence. So we would only consider bypass surgery if your lesion cannot be treated with stents, so it's very extensive, or if it involves the main trunk. Because when it involves the main trunk, too much of the heart muscle is at stake, and stenting is often not the solution. So when is bypass amenable? So you've heard about the classification with SCAD. The situation where bypass will be very challenging will be patients where they have really long extensive dissection, the 2B ones, where the dissection extends to the very tip of the vessel. So you can see the example over here. So the dissection actually starts here, and it goes all the way down to the bottom. So the surgeon would not be able to plug. So normally when you want to do a bypass, the surgeon plugs beyond the blockage. So in type 1 lesion or 2A lesion, you can plug beyond where the dissection is. But in a setting when you have 2B and it goes all the way to the distal part, you'll be suturing onto dissected segments of the arteries, and that's very tough. So you may not be able to open up the artery irrespective of what you try. So when you look at what's out there in terms of data for bypass surgery, the best one here is from the Mayo Clinic, 20 patients. So that's all we have, 20 patients in that series. Other series are limited, 5, 10 patients. What they did say is that the early mortality is actually pretty low, 5%. 1 in 20 patients would die when they undergo bypass surgery for SCAD. But you got to think that those who undergo bypass surgery are very sick already to begin with. So that's not such a bad number. But after you had a bypass surgery, your 5-year survival is actually pretty good. In their series, everyone survived. But the challenge is you may live, but your bypass graft may not survive that. Okay, so in fact, 2/3 of the bypass grafts are gone by the follow-up. Okay, and the reason is because we know that arteries mostly heal. So when the arteries heal, the bypass graft is no longer needed. So there's a lot of competitive flow. So the bypass graft therefore goes down because your own artery is now recanalized itself. So it's not needed anymore. Okay, so that's not such a bad thing. So when we think about bypass surgery, the key thing is it's useful to tie a patient over when they are acutely in dire straits in hospital, when their blood pressure is low and the artery is blocked at that time. So the bypass surgery supplies an interim measure of support for the patient until the arteries heal, and then those grafts are not needed anymore. So this is from Peter Skarsgård, one of a chief of cardiac surgery at my hospital, and those are his recommendations. Is number one, if you had to do a bypass surgery in SCAD patients, you want to avoid the dissected segments of the tissue. So those are the type 2B I mentioned. You can use any grafts, but preferably a high capacity vein graft. Because if you use one of those internal memory grafts, when the flow is competitive, they tend to shut down more easily than the vein grafts, all right? So typically go for the vein grafts. And really we're operating for patients to actually achieve survival for the patients, meaning having them survive the hospitalization, but not talking about long-term patency. Now, so moving on now away from acute hospital management, what about the long-term medical treatment part? I've alluded to the fact that we need aspirin and beta blockers long term, and there was a question earlier about what is the long-term outcomes after you survive hospital. The good news is that mortality is low in hospital for SCAD patients. It's actually 0.1% in our 750 patient series, so very low. And none of these patients subsequently died at 30-day follow-up. So 30-day survival was 99.9% in the Canadian SCAD study, which is really good. But the challenge is the long-term. Patients with SCAD, once they had a SCAD event, they are at risk for recurrent heart attack. Why? Well, because you had a SCAD for Two reasons. Number one, your arteries are frail to begin with. You have some sort of arteriopathy, which Dr. Kim will talk about later, what those arteriopathies are, makes your arteries weak. And so you are prone to that lifelong. And typically there's something else that then triggers your heart attack. So that usually is an emotional stress or a physical stress that triggers you when your arteries are already weak. It's like the combination of, bad things happening all in the same go. And so you are at risk for a recurrent heart attack down the road, and most of these recurrent heart attack in the future are due to SCAD. So the incidence of recurrent MI in our series is 5% MI rate per year, and recurrent SCAD is 3% per year. In the literature, you see recurrent SCAD about 20 to 25% over 5 years. And I think our recurrent rate in our series is a little bit lower because I think we strongly advocate beta blockers, and we also strongly advocate a couple of things which I'll show you here. So strategies to prevent recurrent SCAD. Number one, beta blockers. Number two, you really need to maximize your blood pressure management. Yes. So every year, your risk of having another heart attack is 5%. So in 5 years, 25%, you have 25% incidence of a heart attack in the next 5 years. So every year, 3% SCAD. Okay, I have a SCAD today. The next year, I have a 3% chance of another SCAD, and that adds up. Okay, so in 10 years, I have a 30% risk of having SCAD in our series. All right. So what are the other potential strategies to reduce recurrent SCAD? So I've talked about this. Emotional stress is so important to try and minimize. Right? We know that at least half of patients when they present with SCAD have some sort of emotional triggers. And so very important to have psychosocial support, peer group support to try and minimize that level of emotional stress. Physical stress as well. We talk about avoiding heavy weightlifting, and then there is a session later which will talk about exercise post-SCAD, so I won't go into too much detail. Avoiding competitive sports. And then amongst other important strategies are avoiding the hormonal therapies that you heard about earlier, avoiding activities that increases your Valsalva, where you have to bear down. Again, think about when you're bearing down, you're increasing the intrathoracic pressure. Again, you're increasing the arterial shear stress. All right, so I've had patients have recurrent tear when they're coughing for like 2 days because they had this horrible, postnasal drip, and they're coughing and retching, and now they come in with SCAD. So this is a real thing that happens. And straining intensely for a bowel movement, you can use a stool softener to try to avoid that. But it's actually real. People have had, straining for a couple of days, and boom, they have the SCAD event. And avoiding future pregnancy as well. That's another strategy. And in terms of exercise post-SCAD, I won't go into this in more detail. You have a session about this later. Again, listen to your body. Really think Zen. Avoid heavy weights. We don't really know what is the threshold that is safe, but I know that most women don't need to lift more than 30 pounds. You don't need to lift a 50-pound luggage. You can get the men to do that. And when men have SCAD, a lot of them have been lifting 100 pounds, weights before they have SCAD. And I said, well, you don't need to do 100 pounds in the gym. You can do max of 30 to 50 pounds, right? And so these are thresholds that enables you to live in a regular lifestyle without having to go excessive. And there's no need to go excessive, especially with competitive, high-intensity sports. Don't do the Orange Theory, anaerobic threshold type of activities. Don't need to do that. You want to stay active, but you don't need to go to the extreme. And join a rehab program. I'll skip this part of it, but we do have a SCAD-specific rehab program where we target not only the physical activities, but the psychosocial aspects of patients. And in the patients who undergo our dedicated SCAD rehab program, 27% had psychiatry referral, 28% had social worker referral. So that's, I think, a very holistic approach to managing patients after a SCAD event. Not only exercise, but think about their other lifestyle needs. And we know that patients who went through cardiac rehab program, they had lower chest pain at completion. They were able to exercise more. In fact, in our series, patients underwent the SCAD-specific rehab actually had lower recurrent bad events compared to patients who did not, and also their depression score reduced as well. So all in all, cardiac rehab is a good thing. So in summary, SCAD is a very important cause of heart attack in women. Management not only acutely, but we got to think long term because recurrent events are very high, and we all need to do you need to do your own part, and your clinicians need to do their part in trying to make sure that you adhere to your medications, and you really want to avoid all these other potential triggers. All the evidence that might not be there, but we definitely have seen evidence where you have these emotional and physical triggers and you have SCAD. So better safe than be sorry, right? So try to minimize those risks. Thank you.